Hypochlorite accident. Accidental injection of sodium hypochlorite into the periapical tissues. All right, so that's what it means. A hypochlorite accident refers to any event where sodium hypochlorite is expressed beyond the apex of a tooth and the patient immediately manifests some combination of the following symptoms: severe pain, even in the areas that were previously anesthetized for dental treatment, swelling, profuse bleeding, both through the tooth and outside, forceful injection of the sodium hypochlorite, having an irrigating needle wedged into a root canal, not using a specific irrigating needle, using a regular needle. Irrigating needle, even if you use an irrigating needle, if you wedge it in, if it's wedged into a root canal, and then you forcefully inject the solution, you get a sodium hypochlorite accident. Okay. You must recognize immediately that there was a sodium hypochlorite accident. Okay. Immediate problem of pain and swelling should be attended to first. A regional block with a long-acting anesthetic solution, such as Marcaine, should be administered. With the irritant spreading rapidly over a wide range, pain management is difficult because symptoms from distant anatomic structures will continue to cause discomfort. This also explains the extreme pain felt during the incident, despite establishment of adequate local anesthesia before treatment. Calm the patient down. Monitor the tooth for the next 30 minutes. A bloody exudate may discharge back into the canal. This bleeding is the body's reaction to the hypo. To encourage further drainage from the periapical tissues, the fluid should be removed with a high volume evacuation. If drainage is persistent, the clinician should consider leaving the tooth open. You can leave the tooth open over the next 24 hours. The clinician should consider antibiotic coverage. The clinician should consider an analgesics, but avoid aspirin and NSAID because they can cause bleeding, so stick to acetaminophen narcotic combination. You can prescribe corticosteroids. Steroids will help minimize the ensuing inflammatory process. The patient should be given home care instructions. For the first 6 hours, the patient should use cold compresses and then warm compresses thereafter. The clinician should consider referring the patient, either refer the patient to an endodontist or an oral surgeon. Prevention. A hypochlorite accident is completely avoidable. As an endodontic irrigant, hypochlorite solution is meant to flush debris from the root canal system. Part of the efficacy of the hypochlorite depends on the volume of irrigation, as well as the depth of penetration of the irrigating needle. Even so, the solution must be delivered in a passive manner to avoid apical extrusion. As root canals are chronally flared during the cleansing and shaping process, the irrigating needle can penetrate deeper into the canal while still not binding against the walls. Okay, so the irrigating needle should be bent at the center to confine the tip of the needle to higher levels in the root canal and to facilitate direct access to all teeth. regardless of the angulation. The needle should never be placed so deeply into the canal that it binds against the walls. Look at these poor people. The needle should be oscillated in and out of the canal to ensure that the tip is free to express irrigant without resistance. The irrigant should be expressed slowly and gently. Irrigation should be stopped if the needle jams or if there is any detectable resistance on pressing against the plunger of the syringe. The hub of the needle should be checked for a tight fit to prevent inadvertent separation, accidental exposure of the irrigant to the patient's eyes. Okay, let's talk about management of abscesses and cellulitis. In other words, let's talk about when to prescribe antibiotics and when not to prescribe antibiotics. The prescription of antibiotics is not recommended for irreversible pulpitis. Is not recommended for irreversible pulpitis, acute apical periodontitis, a draining sinus tract, after endodontic surgery or after incision for drainage of a localized swelling. If there is no fever, there is no cellulitis, there is no lymphadenopathy, you don't prescribe antibiotics. The use of adjunctive antibiotics is recommended in conjunction with appropriate endodontic treatment for progressive or persistent infections or both, which have any of the following systematic signs and symptoms. These include fever, more than 100 degrees Fahrenheit, malaise, cellulitis, unexplained trismus, and progressive or persistent swelling or both. Other than that, there's no need for antibiotics. With these signs and symptoms, the prescription of an antibiotic is indicated as adjunctive therapy to effective debridement of the root canal system. Remember the case that I presented the other day? The clinician had put the patient on 250 milligrams of amoxicillin to be taken twice a day for 10 days. All right. Here you go. And I was so frustrated. I was so upset with this clinician. Here we go. I know this book by heart. All right, so here we go. A high dose regimen for a short time is preferred to a low dose for a longer time. The latter is much more likely to select for resistant organisms. Now, if you're prescribing amoxicillin, an oral loading dose of 1,000 milligrams of amoxicillin should be followed by 500 milligrams every 8 hours for 6 to 10 days. Now, let's say you put a patient on penicillin, and if after 2 or 3 days of penicillin therapy, you don't see any improvement of the patient's signs and symptoms, then you can add metronidazole to the penicillin. Okay? After reviewing the diagnosis and appropriate drainage, the addition of metronidazole to penicillin is indicated. Metronidazole is prescribed in a loading dose of 500 milligrams, followed by 250 to 500 milligrams every 6 hours. Penicillin should be continued because metronidazole is not effective against facultative bacteria. Patient taking metronidazole should not consume alcohol during therapy and for at least 3 days afterward. And of course, clindamycin is recommended for patients with a serious infection and an allergy to penicillin. Clindamycin should be prescribed with a 300 milligram loading dose and then 150 to 300 milligrams every 6 hours for 6 to 10 days.